Hello, and welcome to a bonus episode of HIV Reimagined, the podcast where we have conversations with clients, health workers, and experts on the front line of HIV service delivery to explore how things can be done differently. How can we change while still achieving the goal of ending AIDS in children? You can listen back to the first season wherever you get your podcasts. I am your host, Dr. Shaffiq Essajee from UNICEF's HIV team. And today on this special bonus podcast, we're talking about decoding EMTCT, the elimination of mother to child transmission. What does it take to end transmission from mother to child? And I'm joined in the studio by two special guests. So, a warm welcome to Joy Crawford, Executive Director of Eve for Life Jamaica, and Dr. Natalia Beer, who is from the Ministry of Health in Belize. Welcome to you both.
Thank you so much. Thank you for my colleagues being here. It's been a pleasure to participate in this conversation.
Thank you, Dr. Essajee, for this opportunity. It's a pleasure to be here today with you.
Great. And Joy and Natalia, please feel free to call me Shafiq. So, we're also going to be hearing from someone who knows a great deal about working in HIV healthcare at the front lines.
My name is Nurse Lind. I'll be sharing experiences on providing prenatal care, especially to our HIV positive mothers here in Belize.
We're going to be hearing from Nurse Lind in a little bit more detail shortly. But when it comes to children, usually we think of HIV as being most associated with sub-Saharan Africa. That's the epicenter of the pediatric AIDS epidemic. But of course, the virus knows no geographic boundaries and affects children and communities across the world. So today, we're going to shift gears a little bit and focus on the Caribbean, specifically two countries, Jamaica and Belize, that have achieved the elusive goal of eliminating vertical transmission of HIV from their mothers to children. Worth taking a moment to think about how incredible that achievement is. 2 decades ago, close to 500,000 babies were newly infected with HIV every year. But with affordable, high quality treatment, millions of children have been saved from acquiring the infection. In 2023, UNICEF estimates that there were fewer than 120,000 new infections in children, which is a decline of more than 75%. I think eliminating vertical transmission is one of the most remarkable public health achievements of our time. What does it take to get us to that goal? And how did communities and health facilities come together to make it happen? Joy, let's start with you. You work with a community organization, Eve for Life in Jamaica. From your perspective, what would you pull out as the key factor that has been critical to achieving elimination of vertical transmission in your country?
Okay, great. I think from the perspective of E4 Life, we were very integral at the setup of the country's national steering committee that would now look at the different components and the different pillars that were required for us to achieve the benchmark to get the status. We were able to bring the client's view, and not just a client view, but the adolescent client who was really coming up as one of the biggest groups who were in the PMTCT clinics in terms of pregnancy and positive. So here in Jamaica, we routinely screen all our pregnant mothers for HIV. So that's our policy. Now, what you find is that the group of adolescent girls, by virtue of some of our other SRH policies, become a group that doesn't necessarily show up readily early in pregnancy, and or if they do come into the antenatal service, they sometimes default because they don't have personal agency. They may be in a family that is not very supportive of them to support them coming to the clinic, or some of them are unfortunately in domestic violence relationships and they don't have that autonomy in terms of compliance. So some of those issues makes them very high risk for transmission. So as an organization, I think we were able to play a real key role in the national response. So what you'd have practical is that the girl would show up at the antenatal clinic and she would have her routine test done. And on her diagnosis of HIV, then the health clinics that we were partnering with would now refer that young lady to E for Life while they're doing the treatment we provide that therapeutic, holistic community around her. And we became her surrogate mother. We became the aunt. We became the person who would follow her to clinic, would ensure that she was taking her antiretrovirals, and that was looking at how ready she is for parenting, how ready she's going to be for delivery, what's going to happen to her after. So those other pieces that would be required for her to stay in care and to do well throughout the pregnancy and after. As an organization, we're able to do that. The other thing for me, which I think was one of the greater things, is that we were now able to have that discussion at a one-on-one level and at a group level as to how important it is for the mother to play a role in prevention. So it's okay when the healthcare worker is doing what they have to do. But if the mothers are not motivated themselves, then of course the compliance won't be there.
I think you're highlighting two really important facts here. Natalia, let me turn to you because you're in Belize, you're neighbors, but each country has its own very important and unique context. And yet, in Belize, you too have been able to achieve this elusive goal of elimination of vertical transmission. Are there things that Joy has said that resonate with your own experience?
Yes, thanks, Shaffiq. I want to start with mentioning that the elimination of mother to child transmission of HIV and syphilis is a priority of the government of Belize. And I mention this because we need inputs for the program. So we have secured with the government the 100% of the estimated budget for the prevention and control of the EMTCT in Belize. Elements of success for the elimination, number one is the heightened surveillance, the dedication and commitment of healthcare workers, especially the public health nurses and the rural health nurses. They go the extra mile following up these women to ensure that they get all the services due. I think one of the lessons learned, these are voluntary services. They are not mandatory. And we have more than 20 encounters that are needed for each woman that is diagnosed with HIV or syphilis during pregnancy. And at each of these encounters, we must provide information on why we need to do A, B, or C. So they have to accept the services for us to be able to accomplish this status of eliminating mother-to-child transmission of HIV and syphilis. So,
Natalia, thank you. You reminded us that really that budget piece is really critical. If you don't have government buy-in and the willingness to fund and support the programs, you can't achieve the success. But that's not the only thing you need. You need that secret sauce, the healthcare worker who's dedicated, who's committed, who's informed, and who's determined to capture every woman under her care and make sure that she's coming back for services. And we always like to hear from people who are on the front line and integral to delivering services. So let's go back to Nurse Lind, because she has 25 years of experience working in HIV care. So we wanted to hear some of her perspectives on really what she has found to be the most effective way to get her clients to stay on treatment and to remain engaged in care.
So in my experience, the most effective way in helping mothers adhere to their treatment plans is definitely building a rapport with that patient. If you don't build a rapport, they don't trust you. And one of the very main things is confidentiality. There's still a very high stigma against people being HIV positive. And so we need to ensure or let that patient understand that their information is 100% confidential with us and they can trust us with their information and whatever their needs are. Once there is a mother who is positive, then we build that rapport with that mother and let her understand the importance of being on the ARVs to keep the viral load low and to prevent the transmission of HIV to baby. So once the mother understands that with the education that we do, then that helps with the compliance of her taking her medication on time. And we have the adherence counselors who assist us so that if for any reason that patient does not come in on time when that medication is due, then we reach out to the compliance counselor and we go looking for them at their houses or wherever they can be found. One of the main reasons why our mothers would have issues with sticking to their treatment plans, I would go back to not wanting people to know their status. For the most part, they choose not to let the spouse know what the status is. So sometimes we have to think of different ways to get that patient to take the medication every day. In this day and age of accessibility to internet, people just go on the internet and look for a medication and find out what it's for. So sometimes we have to be putting medication in vitamin bottle so that whoever they're living at home with feels that it's just a vitamin they're taking every day. Then we try to find ways how they can get the medication every day without the other person finding out what it is. People get more jittery when they know that they have to deal with like a whole streamline of people in regard to their care, as opposed to if maybe it's only 2 or 3 persons dealing with them and they get everything they need. People are always concerned about confidentiality and the confidentiality of the system itself. So the least amount of persons involved in the care, the better. We definitely provide a secure space for them. We ensure that they're in a room where there is no other persons coming in or having access while we're having a discussion. If the patient goes to the pharmacy to pick up the medication, then the pharmacist would put that medication in a paper bag so that other clients wouldn't see what they're picking up. If they need access to one of the other services, like the chest clinic, we would go with them and ensure that there is confidentiality so that there are not other persons knowing what they go to access the services for. When the patient comes in, like post-delivery, we explain to them that they need to bring in a bag because we provide the formula for them to formula feed. So other persons don't see that we're giving formula because we're also a baby-friendly clinic. So we don't generally allow other people to bottle feed within the clinic. It's only breastfeeding. As a part of confidentiality, we don't let other people see that we're giving the formula because people also know that when we give formula, for some reason, the public learns our little systems that we offer. So once they see you're getting milk from the clinic, then they start to become suspicious, right? Our platforms as well. We have internationally the code. There is a specific code for HIV, but within the maternal and child health section, we don't use that code any at all. We have a specified code that as healthcare workers we know. So that is placed on the card so that when the patient goes to the hospital to deliver, the nurses there sees that code and know that that patient is positive so that they can provide the medication for them pre-delivery time. We have little things that we do to ensure confidentiality of patients.
Fantastic insights. Natalia, you know Nurse Lind personally, so we obviously know that you value her greatly as a
Yes.
member of the ministry's team and of the program. Tell us, what are the things that resonated with you?
Well, Nurse Lynn is one of our wonderful rural health nurses and very knowledgeable of the program, as you can see. Definitely, the issue of confidentiality that she raised is an issue that of concern for all of us at all levels. We have come a long way. We used to have only one clinic countrywide dealing with all HIV patients, and we had special clinics for syphilis and other transmitted infections sexually. But currently, the services are now provided closer to home. We have 6 districts, so all districts have the capacity to provide these services. They also offer transportation. If the woman needs to go and pick up medication and she don't have how to reach to the facility, the ministry will ensure a transport to pick her up and carry her to the health facility to pick up the medication and then to carry her back home. But as I mentioned earlier, the services are not mandatory. They are voluntary. And the confidentiality in a small country like ours play a big role.
It's a real challenge, isn't it? Because you want to have every district having the services available. But that also means that, a woman is right there with her neighbors and her friends and others in her community. receiving potentially HIV related care, she's going to be known in that locality. Whereas if there is a single facility in the country, maybe it offers a little bit more anonymity to an individual. So it's finding that balance and recognizing that stigma and the issue of confidentiality lies at the core of why a service works versus why it falls short.
Yeah.
Joy, you're listening to this with the perspective of a community activist. Can you speak a little bit more about what trust feels like from the community's perspective?
Sure. And just to say, like Natalia, we have a big country, many clinics right across the island, and our situation, I think, is similar, but from a different lens, in that we oftentimes get reports that not all the services that are supposed to be available are actually available on the day when the client reaches the clinic. Even the issue around access to formula, we see that there's a difference in terms of access and availability depending on where you are in the island. So there's this variety and not really a standard. So we have this mixed experience that the clients come back and share. Trust is important. One of the things that was mentioned by nurse is the issue around being baby friendly. That's been one of the big issues for us at a level of the complaints that we get in terms of, am I valued as a HIV positive young mother? Am I valued? Because when I go to the clinic, there seem to be different standards for me. And the issue of this baby friendly is one of the drivers. One of the things that I've been lobbying for a number of years, even when we do our campaigns and when we do our posters, is just to put a line at the bottom that says, if for some reason you can't breastfeed, reach out to this number or something, because there are a number of reasons why women do not breastfeed, and it's not just about HIV. So what are some of the stories we hear? They take the baby to the antenatal clinic, the postnatal clinic, held at a pediatric hospital, but then they're there waiting for 4, 5, 6 hours, and they can't feed the child because they can't breastfeed, and they can't take a bottle out in the clinic. They can't even take a cup out because all of this exposes them, eh? They don't want that. And if they go outside of the waiting room, somebody's going to know something's up, or the security guard is there to police them. So what you find is that a number of our girls, because of this pressure and because we haven't created a space within our policy or our practice that they can be comfortable to still take care of the nutritionally child, they put the breast in the baby's mouth. And then we have another problem.
An interesting viewpoint. Joy, it strikes me that community buy in is really important for leadership, for agency as part of this response. How did you do that in Jamaica?
We were the ones who were engaged to come up with a training and a workshop to bridge the gap for the PMTCT nurses across the island, just to be able to understand the growth and development and the dynamics of how young people think and how do they interact with those of us who are policymakers. And one of the other things that we did was, within our group of girls that we work with, we empower them to become peer support leaders. So they now would carry the information to their own peer group. They say, oh, I'm in a program. This is what I'm learning. This is what I'm benefiting from. I get my care packages. And they would do referrals.
Natalia, from your experience in Belize, have you seen the same thing? Have you thought about how to develop tools so that young women can advocate for themselves and can become peer supporters for each other?
Yeah. What we provide them with is information. We give priority to the one-on-one information, meaning personal counseling sessions, no?
Mm.
Support groups have been difficult. I mean, we're a small country. Everybody know everyone. So it have been one of the issues that we did not overcome, having the support groups for women with HIV, including adolescents. No, I must say that we definitely need to work more on the left side, reducing the HIV infection among women in reproductive age before they become pregnant. So we need to invest more in that. Part of that is to ensure that women have access to family planning, contraception. That is an informed choice, but it allows us to incorporate into the family planning sessions the prevention of HIV. So I'm happy to report that our birth cohort is approximately 7,000 babies per year. Out of that 7,000, we used to have 1,400, 1,500 in adolescent age giving birth. And
Mhm.
that number has fallen to 842. So it dropped almost 50% with the access to contraceptive method to adolescents. So we're not preventing the first pregnancy in adolescents, but we have a postpartum contraception program that we strengthened in the last 5 years. And we strongly believe that that is contributing to prevent second and third pregnancy among adolescents. So,
Important,
yeah.
important work to really take that broader view and recognize the importance of the prevention piece of this. It's not just about eliminating vertical transmission from the positive mums. It's about securing their health as younger women to keep them HIV free and to make sure that they're making informed choices about pregnancy as well. Well, we're going to hear a little bit more from Nurse Lynn, but as we listen, I want you both to think about how we can do things differently. Here at HIV Reimagined, we want to have conversations about change. So it's not about necessarily repeating what we've done before, but identifying what works and how maybe we could improve on that. So let's hear back from Nurse Lind on where we can see improvements.
For the most part, education, education, education. The more people know about HIV and the transmission of parent to child, the better it is. It will encourage them to come into the clinic earlier to know what their status is so they can get early treatment. Maybe it is a worldwide battle. I know here culturally, if you would know that you are pregnant, you wouldn't decide to go to the clinic until you're about 3 months. People need to understand that the minute you miss your menstruation or you find out that you are pregnant, you need to access the clinic. The earlier you learn what your status is, the better it is. Because if you come into the clinic early and you find out that you are HIV positive, then the treatment starts there and then, and you get all the necessary referrals that you need.
Fantastic. Dr. Natalia, I think she's echoing so many things that you've taught us about already. But education, education, education. You've talked about the importance of moving to the left side of the prevention piece. What about even further back, education in schools so that young women, young girls are understanding what their choices are?
Yeah, that's an area that needs strengthening. We usually use the example with the stakeholders that children spend more time in school than with their families throughout the year. No, at least they would go maybe 52 times to church if they go every week. But when they come to health, it's only when they are ill. And we know that adolescents, they usually don't get ill. Relying on the time that health can contribute to prevention is very limited compared to the other opportunities. So we want to strengthen that aspect of outside of the Ministry of Health. How can we improve the preventive interventions?
Takes a village, right? The family, the educator, as well as the health worker.
I won't repeat what Narslin mentioned, but the inputs are how we call it, sine qua non. Without that, we can't have a successful program. And the EMTCT especially needs to be treated as a public good. Women have a choice to go to health facilities that are run by the government, and they have the choice to go to private providers. For us in Belize, it doesn't matter where the woman goes. We provide the screening, diagnosis, treatment, and support services for women, even attending private clinics. That is an element of success because if we do not care for these women in private sector, then it will become a problem for us and we won't be effective in eliminating the transmission from the mother to the child. So Inputs, education, public good, those are key things that we need to make it work. And the preventive aspect, of course.
Joy, if all health workers were like Nurse Lind, I think we wouldn't have as much of a problem. And I know that Eve for Life has done a lot of work with strengthening health worker capacity. How can we enhance that, promote and empower health workers to take the initiative and to be accountable?
What do we need to do about it? Is to continue to ensure that the healthcare worker, who often see them before the community, has not just the information, but the commitment to address the pregnancy beyond just doing the vital signs and monitoring the baby. So we hear the real challenge of not having enough time, more clients and healthcare workers. But I believe that we shouldn't allow anybody to access service and leave and not become more equipped to make their decisions, their health decisions. We have too much of that.
Powerful, very important to consider as part of this. And I think it brings us to a nice point as we get to the end of this episode, because it's time to go back to Nurse Lynn one final time. And there's a question that she has for all of us.
Hi, Shaffiq, Joy, and Dr. Natalia. There is another question I would like to ask. What's in the future in regards to creating a medication that would have less side effects so that patients would be willing to take it every single day without worrying about feeling sick?
Dr. Natalia, let's turn to you. Is Nurse Lynn's dream of a trouble free medication something that's on the horizon?
I mean, that question is just highlighting the complexity of EMTCT. I
Hmm.
recall one of the regional managers mentioning that people that are living with HIV are not dying because of HIV. They're dying of being hungry because they cannot access job. They don't have how to maintain themselves. The medication do havoc to their body. So that is just another dot in this big picture. Like what Miss Joy was mentioning and Nurse Lynn, we did an analysis of some of the cases that we had when we were applying for elimination. We did a dive in into each case, and it was overwhelming the amount of evidence and the burden of social determinants of health when it
Hmm.
comes to EMTCT. We had women that were drug users. We had women with low educational level. We had women that are still in this condition of visiting partner with no other family support. Educational level, don't have a job. It was very hard looking at that situation. Hence the need
It's
for the preventive interventions. No? So
striking, very striking.
I don't have anything on hand right now, but that would be a good dream. And if we put it on paper, maybe it happens, no? But I must say that the dolutegravir is doing wonders. I mean, women in 1 month, 2 months, those levels of the viral load, they go into delivery with non-detected viral load or very low count. So yes, ideally, that would help us a lot if we would have medication that cause little or no.
It was as good as dolutegravir.
Yeah.
Joy, let me turn to you because despite these challenges of lifelong medication and difficulties taking the drugs and the social determinants around them, we have achieved this incredible success. How can we sustain these gains after certification? You know, certification is a nice certificate with a nice gold edge on it that says you've been validated. But the real challenge, in a way, is maintaining and sustaining that effort. Give us some advice.
If it's not broken, don't fix it.
Right.
Yep, very important.
We've gotten this far. We have a machinery in place.
Mm-hmm.
We know what to do. Let's just keep doing it. If we become complacent and we stop doing what we did, then we're gonna have lose those gains.
Well, I couldn't put it better myself. Thank you, both of you, so much for your engagement, for your advice, for your thoughts and feelings. Thank you to Nurse Lind for all of her wisdom and her perspective as a provider. Thank you for your time.
Thank you so much.
And as always, if you want to know more about any of the issues that we've discussed today, or to find out more about Joy, Dr. Natalia, or Nurse Lynn, you can head to childrenandaids.org/HIV Reimagined and check out the previous episodes. Thank you very much. I've been your host, and thank you for listening.